director of the NeMO Neuromuscular Omniscience Center in Milan, Italy. She has experience in neuromuscular disorders, both from the clinical and basic science point of view, and she has experience of 22 years. Her main interest was neuromuscular diseases, myotonic disorders, especially the myotonic dystrophies. Since 2013, she was a clinical director at the NeMO Central in Milan. Her field of interest extended to address the spinal muscular atrophy then, and Duchenne muscular dystrophy, as well as amyotrophic lateral sclerosis, amongst other neuromuscular disorders. She is a faculty of the University of Milan since 2006, and the NeMO Center is a university teaching hospital since 2013. دلوقتي هنسمع الأونلاين presentation بتاعت دكتور فاليريا. زيا.
So good morning, everybody. Thanks for this opportunity. I will today speak about spinal muscular atrophy, which is a disease with a wide spectrum. These are my disclosures. And I just want to go through a quick background. Until 2017, when there was a diagnosis, a newly diagnosed of SMA1, there was nothing we could really do except for this part here, which you see on the top. We would discuss the disease severity with the family, and we would then work with them on their family burden with a family consult. And there were two options only: either let nature take its course, or treat with ventilation, which is usually the problem that SMA1 kids have. And if that worked, we would go on with this type of support until there was an IV tolerance, or when that was becoming insufficient, we would then have another family consult and go to discuss either tracheostomy or, again, let nature take its course, which was very sad, as we all know. Luckily, in 2017, the first drug was approved, and that's nusinersen. And since then, we have now a number of ways that we can address SMA, and this is just a summary. So we can either replace SMN1 with gene therapy, or we can work on SMN2 dependent approaches, including Spinraza, nusinersen, or we can work on neuroprotection and muscle atrophy and motor neuron loss. And finally, there's also a part where we can discuss about cell therapy. So the current treatments now for SMA can be summed up in this way. So it's SMN1 gene acting treatments, SMN2 gene modulators, and SMN2 independent drugs. The focus today will be on nusinersen, because this is, we have lots of experience with nusinersen from newborns till adults. And so I thought I would share with you the experience that we are having. So the first thing is, I think one of the most important things which was published and which is actually known is the importance of pre-symptomatic treatment. This applies to the other drugs too, but we have a direct experience with the first drug in which this was tried. And so we have a very long follow-up, and we're actually following one of the 25 kids in this study. So I think this is an important thing to share with you. We all know that SMA is a progressive disease, and this looks like a busy slide, but I'd like you to concentrate on the time frame here from birth till adult life. And you know, there's important milestones here: head control, sit around 6 months, and walking, which is considered to be within normal range, until 18 months. And you know, if there's a pre-symptomatic phase, which is this red curve here, which then drops, and patients usually have a hard time surviving with SMA type 1 if they are not assisted with ventilation and with nutrition. Type 2s move forward, they can sit, but then they still decline and lose the ability to sit, and they never walk. And type 3s, again, they can maybe achieve the ability to stand and walk for a bit, but then they again lose the ability. And this applies so to all SMA types, including the ones who are presenting in later stages of life. All of them are declining. So there is, however, a therapeutic window where we can act and start treating before symptoms are there visible. We know this is a genetic disease, but we are familiar with symptoms coming on later in the course of life. But if we treat early, there's a better chance of improving the milestones, reaching the milestones actually, and giving very much to these kids. So this is the Nurture study, an overview. This was a phase 2 open label multinational single arm study with nusinersen in infants who initiated treatment before they had any type of symptoms. So we did not know when we started whether they would develop SMA 1 or 2. Some could even maybe develop SMA type 3 because the number of copies, as you know, is predictive of the type of severity, but it's not exclusive. And so out of 30 infants which were screened, 25 infants were enrolled and 25 infants were dosed very early in their life. That was before basically within the first month roughly of age, most of them, and some had 2 copies in the end and some had 3 copies. As you see, this is how they were distributed. And now they're all on treatment and none have withdrawn from the study. And we have now roughly almost 5 years of follow-up, and the study has been extended for an additional 3 years. And so we will have a very long follow-up of these kids. And I think this is something that needs to be given credit for, because having these kids followed for such a long time, even with a drug that has been approved worldwide, is something that's very important, because we will provide data on the safety and on the efficacy of this drug in 25 kids. Which were the primary endpoints here? Well, we're talking about kids who had no symptoms, but who could actually develop SMA 1, the ones with 2 copies, or SMA 2, the ones with 3 copies mostly. And so it was reasonable to think of primary endpoints, thinking of death or respiratory intervention. And as you see, first of all of the kids are alive and none require permanent ventilation as today. Only 4 have required ventilation for some support during infections, which is quite normal for an increase in secretions, but that's transitory and has not been limiting for ventilatory support. And if we look at the Chopin-10, which you know is a neuromuscular scale, with the maximum score of 64. The green are the 3 copies of SMN2 and the blue is the 2 copies of SMN2. And this is basically the natural history where the kids start, where the neonates start, usually with this type of level of score. And this is where the kids started, which is right, because they were supposed to have no symptoms when treatment was started. And it's easy to tell the difference. This is what kids would normally do without the treatment. This is what kids would do with the treatment, did with the treatment. 2 copies and 3 copies. The 3 copies, of course, went better than the 2 copies. But you see that the way the Kaplan-Meier plot actually was very good for both type of kids. And I think this is something which can be easily seen here too, in support of the pre-symptomatic treatment. Now, these are the studies which are very familiar to you, the NDEAR studies with the infantile forms, with the gray and the orange, or the ones then switching to treatment. And these are, again, the Nurture study babies. And you see there's a wide range of differences, even the ones who were on a sham control study and then were started on nusinersen, they did actually catch up and improved. So actually, in fact, strongly supporting that the drug is acting with efficacy even when it's starting later on. However, it's quite clear from these curves that the earlier you start, the better outcome, no matter the number of copies. So I think this is something we should bear in mind. And all these bar charts here represent kids. And you see that it's 25 of the kids, and the ages here are on the x-axis. And if you look at not only all the kids sat without support, which is unusual for an SMA kid, as you know, but most of them did within the time frame expected for physiological kids with no SMN1 deletion. And the same, the walking with assistance, again, within the time frame, most of the kids. And if we then look walking alone, most of the kids again. And by now, some of these dots are also moving into the walking alone part. So it's really something which is unusual, which has changed the natural history of the disease. And this is a summary showing how all of the kids have achieved the motor milestones, which is not predictable by having an SMA deletion. And not only that, but it's also, if we see it's 25 out of 25 sitting without support, if we really want to look at the gross motor milestones, 25 of 25 now walking with assistance, and 22 of 25 walking alone. And again, we know that the number of SMN2 copies predict the outcome, but there's now other things which are becoming more clear as we move along. One of them is the neurofilaments, and this is something very important for the neonates treated very early in their time course, because they have very high values compared to normal controls when they start treatment prior to starting. And as soon as they finish the loading dose, and as you know, that's 4 intrathecal injections within the 2 months, the level of the neurofilaments, heavy chains drop, and they maintain at this sort of more reasonable level for the following assessments. And this is in line with improvement. And in fact, the way they drop and the level they reach is predictive of their motor milestone. It's predictive of how they would be walking alone. So I think, again, this is something very important as a biomarker to consider for this type of treatment. And again, weight for age is again a predictor of motor function, probably in relation with the distribution of the drug, even though the distribution of the drug is based on the amount of CSF, which is something which is sort of not variable amongst the kids. But again, this is something that's important to consider. And the CMAP amplitude, again, is a predictor of motor function. This is important because even though these kids were pre-symptomatic, now as a retrospective consideration, and as more and more data is becoming available, we know that the higher the CMAP amplitude, even within the normal range, the better that correlates with motor function, so is a predictor of motor function. So again, this is something which is important to consider. I also would like to point out other oral bulbar functions in SMA in this type of study, which is very important because we know that SMA1 kids have not only respiratory problems, they also have nutritional problems. And nutrition and swallowing functions are very critical for these babies. And so there may be different types of feeding and swallowing problems. You know, there may be, if we look at the SMA1's reports, the sample is not very big. We have to consider that survival is also something which was critical before these treatments became available. So the data there is not as large as we may wish. but you know, there may be problems with adapting food. Patients get tired, their meal time gets very long, they're not drinking enough. And so it really becomes crucial to address these issues. And in fact, there may be, these type of problems are, of course, not with the neonates, but there may be tongue weakness, which is underestimated. And these things are things that may be considered in the older age patients, but this is to stress that it's not only the bulbar function which is affected. And one other criticality that there may be, whereas we have very good predictive scales for the motor function, we have the respiratory test to know what's going on with the gas exchange. There may be some problems with monitoring oral bulbar functions relative to swallowing abilities. And so, in fact, there became a need to have a specific scale to address this, and this was thought for this study too, and it was used as the study moved along. So this is called the PASA scale, which is a comprehensive tool to assess swallowing ability. And as you see, it's quite easy and quick and straightforward. There's from a score from 4 to 0, you either never experience that type of problem, which may be problems with general feeding, with liquids, or with eating solid foods, or always. And of course, the higher the scores, the better, because it means you do not have that problem. And then there's an assessment of the swallowing concerns. Again, if you are worried, you strongly agree. If you strongly disagree, it means you're not worried. So again, the higher the scores, the better. And one other thing I want to point out is that there is a general concept that the intrathecal injection, because it's mostly delivered at the lumbar level here, where we normally have a lumbar puncture, does not really affect the brainstem, and so the oral bulbar muscles innervated by the motor neurons in the brainstem. But in fact, I just wanted to show you this. Black is the delivery of the azo that was injected at the lumbar level, and you see it does get distributed up until up to the brain level, and it does get to the cortical regions. Of course, it's in non-human primates, but there's reason to think, because of these results, that this is what's happening in the kids too. So most of the infants in the nurture study had good sucking and swallowing abilities. And as you see, 100% with the 3 copies. So the light blue here is the 3 copies and the blue is the 2 copies. All of them have good sucking and swallowing abilities, and 80% of them have, and only a few need to have a problem and may need some feeding abilities or some dietary modifications once they have once they experience some difficulty, but it's transitory. And again, never required a tube feeding. All of the 3 copies, and more than 70% of the kids with the 2 copies. And again, even the problem with the saliva and the drooling, which is again something which is important. So I think this is, for the 3 copies, it's an excellent result, but also for the 2 copies, it's most of the kids are not having problems with the swallowing and nutrition. So I think this is another thing that needs to be considered. And when we go back to the PASA questionnaire, remember that the higher the scores, the better. When we're talking general feeding, we see that most of the responses are at the high, never experience a problem, or rarely experience a problem. And all of the 3 SMN 2 copies babies have never experienced problems. So this corresponds to what I showed you. It corresponds to the questionnaire, which proves to be a valid way to assess this. The same thing with drinking liquids, same thing with eating solid foods. And again, with the swallowing concerns, most of the patients parents disagree or strongly disagree, according to whether the 3 copies babies or the 2 copies babies, which is in any case an excellent result. And it's not only efficacy, it's also safety. It was well tolerated. No new safety concerns were identified. And so basically, as a sum up, there were 0 serious adverse events related to the study drug. And the things that we hear about having proteinuria are things which are mild, and increase in the respiratory problems are related to the disease, and it's transitory, and it's normal for a kid, for a neonate anyway, and it's not drug related, and it's not related to the lumbar puncture. So I think this is the first part of my presentation really points out to how important it is to start early. And I also want to stress that as a neurologist, I am an adult neurologist, but I've always seen and followed, taken care of kids too. And I must say that having to think of a lumbar puncture at a very early age, because we're talking a few weeks of age, was initially considered, even at our place and even by myself personally, as something which would be very burdensome for the kid and for us too, and for the parents. And I must say that this is not what happened in real life when we experienced and we started the study, and then we also had the experience with the expanded access process, and we treated more than 100 kids. This was much easier and doable than we thought, and it was actually even technically more doable for the smaller ones than for the older kids and grown-ups. Because of the spine, there was no scoliosis, it was very easily to access, and the kids really had no post-lumbar puncture syndrome. Of course, there needs to be experience in doing this. I do not want to give the impression I am underestimating that it's a lumbar puncture, but it's very doable, and none of them have dropped out because of this. So I think this is an important thing. And if we move on to look at the long-term safety and efficacy from the other studies, which are in the older kids and the real world data, we are basically confirming the efficacy and the safety. Of course, this is more so in the pre-symptomatic kids than what we see in kids who already have some type of impairment. And no matter the number of copies, one other thing which really affects the outcome is the functional level at which the kids are starting to be dosed. So we know that the SHINE primary objective, SHINE is a long-term extension study of symptomatic kids. So this is now different. They were participants from the NDIR treated with nusinersen or the sham control. There were participants from the CHERISH study, again with nusinersen or sham control. And there were also participants from other studies, which also included later onset and more grown-ups. And the dosing was the same type of program that we followed. And we looked now at, with this study, the secondary objectives were also not only safety and tolerability, but the secondary objectives were the efficacy, looking at the Hammersmith functional motor scale and the revised upper limb module. So this is also something important for the sitters, because if we look at the efficacy of the upper arm, it's also giving us information which we would not be able to obtain. And one important thing which should sort of give us more confidence that we really have a good option for these patients is not only the efficacy data, which I will show you, and the safety data, but also that the follow-up is really a long-term extension study. We are having individuals now who are being followed for a relatively long period of time. And what we are observing is that at least they are either staying stable or improving in the studies. And so this is something which keeps going on. And I think it's another thing that needs to be considered. So these are the efficacy and the benefits over the long-term period. You see we're talking the chopping 10, again, it's motor function, +5 points and +17 points. we know that it's not just, changing numbers in the scale, it's that these type of increases have a clinically meaningful significance for the kids and for the patients or the older boys and girls treated. And we also have to think that although this may seem something which is not exceptional, it's not a result that's shocking like it is with the pre-symptomatic kids who are now walking and jumping around. But if you consider what would happen without treatment, you would not only not gain, but you would lose points. And so the delta becomes bigger, and the results should be emphasized as being positive because of this thing that one always has to bear in mind. And you see, if we want to focus on the motor milestones, if we look at the percentages, you see that they are increasing. And so more than a half, 64% are sitting without support. And as we move along, and the motor milestones that they are achieving are actually increasing as the follow-up occurs. And I think this is something which are really, again, if we compare the delta, something around a 2-point increase. If we consider that they would have lost points, even with the Hammersmith, I think this is something which needs to be kept in mind. And even the ones with the later onset SMA, which are those coming from the Cherish and Shine studies, you do again see the same increase in the trends of the curve, which are still increasing over time. Of course, the bigger differences are at the beginning, and then they tend to level up. But again, if we think of how that would work with without treatment, the results are even more significant. And the safety profile remains consistent over time. Actually, some of the things even become less evident as you keep treating the patients. And this is from my personal experience. Even the post-lumbar puncture in some of the older kids, which may be there, maybe starting around 8 to 10 years of age, they start sort of getting less of it as more lumbar punctures are performed. And so again, this is something which needs to be considered. But the safety is consistent amongst all the studies, amongst all the people who are now on treatment and over time, which again is something which is important. And it's not just the studies, which one may think, these are the best patients we are including in there, but it's also the real world data, which is providing us with very important information. The two most significant studies are the ones coming from the German cohorts, and the ones, as you see, the numbers here are actually now the numbers are increasing even in the follow-ups. The German cohorts and the Italian cohorts, and the data are consistent because, as you see, this looks like a busy slide, but in fact the red and green colors show that the sample sizes. So the greens are the ones with the most significant percentages of responding patients, but you see the percentages in if we look at all the types of SMA put together, we still get very good response rate. More than 50% up to almost 70% are responding. And this is especially interesting because it's as time progresses, and the same trend is maintained if we split the results according to the different types. So again, this is supporting efficacy and safety. And this has been done with a meta-analysis from a study that we worked on together with Professor Mercuri and his team, who were the leaders on this analysis. We looked at a comprehensive literature review was conducted with a total of 30 papers that were selected and analyzed, which was a very tough work to do. And of these, 15 on adults treated and 10 on the natural history, and the same with children, as you see. So basically we compared all the papers that were out there with treatment and without treatment in adults and children, and we plotted the results as you see here. This is the sort of the cutoff point when you see that the curve is shifting on the right. It's a positive result, and the ones who are sort of on the midline are staying stable, or these are all the untreated cohorts, as you see. And there's a definite difference between the treated cohorts, which are basically all sitting here, compared to the untreated ones. So this is for the adults, but you see the same thing for the children. And so again, this is something that putting all the studies together, and you see they're coming from different places worldwide, there is a consistent idea that treatment is bringing improvement to these patients, and the gain in these scales may not be as shocking as I'm saying, but if we compare it to the untreated patients, there's a significant difference for many of the scales that are considered. And so it's important to keep this in mind, and and one other message here is to test the patients who are on treatment according to their age, of course, but with the different scales, because there may be things that are captured in one better than they're captured in another, which is basically because the patients are very different amongst the cohorts. So as you see, this is again, on motor function measures, you see that there's all very significant and positive results here. So basically, we think that in every patient subgroup, there was an improvement in motor function when the patients were treated, and on many of the scales, as I say. So, and there was an actual difference with the untreated cohorts, and this is coming from very different areas worldwide, and I think this is something which cannot be disregarded. And finally, I just want to give some of my experience that I have had both as part of the International SMA Consortium, which, as you see, involves different clinical centers. The NeMO centers are dedicated neuromuscular centers. I will be focusing on the ones at our site. We're following now more than 125 patients with SMA. As a whole, there's 571 patients, and this is the distribution, as you see. And of these, 192 are adults. Relatively young age group, as you see, around 36 years, but the age range varies from 18 to 74, and only a minority are included in randomized clinical trials. So these are really real-world data coming from our site. And we looked at some of the results of some of the adults coming back to our site, because with new treatments becoming available, many of the patients came back and asked for treatment. And so we described the population and to see what was going on. And what we saw was that there was no difference in the age and disease duration, that the scores were higher in the old versus the new patients, probably because they were more regularly followed and sort of followed standards of care more. And so in any case, I think that this brings a message that with treatment, more and more patients are coming along, and we need to know how to approach them, and we need to be properly trained to obtain the data that's needed to monitor treatment. And we also have to remember that there's a variability within SMAs, but also within even one class of SMA, because if we look at neuromotor progression and we think, oh yes, it's an SMA3, it may change if we're thinking SMA3A or 3B. And we need to know that according to the age of onset, there's a prediction of when they will lose ambulation. And this is important when we start treatment and when we talk of expectations, because we can actually change things, but this is something that needs to be known prior to starting treatment. And now there's a whole scenario which is changing with these treatments becoming available. So if we start with an SMA, we were used to thinking of SMA ones as non-sitters, but actually now we can think of SMAs are being able to sit, to actually then move around with their hands, and as you will see, there's more and more experience. There's SMA1 kids with treatment who are now being able to stand. This is how they started off. And with training, mobilization, management of posture, I want to share this with you because it's not just treatment. It needs to be coupled with standards of care that need to be followed. So this is something important, which needs to be kept in mind. And this also is SMA3 kids which are walking and they maintain their ability to walk with treatment, and the same applies to the adults. And I finally want to end up with the nurture studies, because these are the pre-treated babies dosed at day 41, as I say, and you see this is 2 copies of SMN2, and you see that the kid is moving along very nicely. And this again is something which is very important for us to consider. These are all walkers, and so it's something which is very exciting for us. And there's also some things that are need to be considered with ventilation also. It's not only affecting motor function. This is from the experience that we had, that there's also need to monitor ventilation, because this is also being affected. Remember that the 25 nurture kids none are on permanent ventilation. So this is something important. There's also one thing, again, I wanted to share this case with you, because even the patients who have gone through spine surgery, as you see here, can receive intrathecal injections. And based on the data that's available for this age range, the adolescent and the young adults, which, as I showed you, have promising results even with the intrathecal injections, there's a way to approach the lumbar space with echo-guided or with fluoroscopy, which is very doable for these patients. And so this is one of our adolescents who was treated and who is now very happy with her new posture. And finally, these are our kids, which are walking around and very happy. And again, no worries about now we've been following this kid for up to 5 years. And so there's no side effects and doing very well, no signs at all of SMA. And these kids, as I say, are really doing very nicely. And even the ones who are now maybe having some very mild or minimal signs, they are nothing that can, that's sort of a reason to stop the intrathecal injections. And safety, again, is not at all a concern. It's long-term safety up to now more than 7 years of treatment. And so in the maintenance phases, there's only 3 doses required. That's every 4 months. And it does cross the blood-brain barrier, but it's also having a low drug interaction with other drugs or other systems that are working, like the common transporters for or inhibitors that are very useful for our bodies. And there's no seeding dose effect observed. Actually, the efficacy is maintained as time passes. There's minimal off-target and peripheral effects and toxicity, which, because this is a non-target drug, and yes, it's intrathecal, but we have to also remember that we are targeting motor neurons, which is exactly where we want the drug to be. There's no fertility issues so far. So again, this is something that is to consider when we're talking adolescents and young adults. And actually the lumbar puncture, as I said, was much more doable than what we initially thought, and there was no immune adverse events that have been experienced by the patients. So we are quite confident with this type of treatment, and we're glad that we can offer it to our patients, whether they're newborns or adults. And I want to thank all the staff that's working with me, both in Milan and Rome, Professor Mercuri, who is coordinating the whole Italian group. And thank you for your attention. Happy to take questions.
Okay, Professor Valeria, thank you so much. And she's now available online for any question. أحب أطمنكم بعد السيشن بعد الكويشن answers هنend our session عشان كلنا تعبانين وجعانين وهنأجل محاضرة الدكتور طارق ودكتورة مع بكرة إن شاء الله. 12:30 Dr. Valeria, Dr. Maha, lecturer of pediatric neurology at Shamsi University. She has a question.
Thank you, Doctor, for your very informative lecture. So my question is about, so here in Egypt, we do not have detection or screening program for pre-symptomatic cases of SMA. So I want to know your opinion about ordering the priority. Should we go for treatment of type 1, which is the most severe form and with most complication and I think less response, or for type 2 or 3 if we don't have like screening program for pre-symptomatic or who showed the best response?
So thank you for your question. Can you hear me all right? Can you hear me?
Yeah, right.
Okay. So I don't think that we have to prioritize only based on the type of SMA, because SMA1 kids may respond very well, even though they have symptoms. So it really depends on the functional status how the patient starts. So if they are very severe, the expectations may of course be milder, but if they are, even though with SMA1, you know, we are used to using the classification like 1.5, 1.9, you can expect that these kids will also respond. So I would not focus only on the SMA2 or 3 types for the priority, because this is a treatment which has shown response even in SMA1. It depends on how the patient starts. Of course, if it's very severe, the possibilities are reduced.
Thank you.
Okay, thank you very much, Dr. Valeria. I have a question for you. You know, the SMA now is giving us a huge burden on the ICU, on our ICU and on our intensive care, and they are really the least prioritized in our PICUs. So what I'm asking you, if we introduce the SMA treatment for children type 1 after they have symptomatized, what repercussion will this have on our ICUs? Will it be a more gush into the need of other ICUs because they are living longer, or what's your impression?
So thank you. This is an important question, because of course now with these treatments available, we are making the kids luckily feel better, but of course the burden is sort of spread over the ears. Now, depending on if a patient with SMA1 has a tracheo because of respiratory involvement, or needs continuous non-invasive ventilation, for instance, the possibility of having this improve are less than the motor response. It depends on again on how severe the patient starts, but we are seeing continuous improvements or stabilization even in the severe ones. So I think that we can't generalize. We should really think on a patient-to-patient basis. Of course, we are trying to reduce the burden for the intensive, for the kids and families, first of all, and also for the physicians in the intensive care. How the response would be on the patients on high on ventilation or with a tracheo, I would not think that any of these treatments would really remove this type of burden when it's there already. But that's why pre-symptomatic or early treatment is very important, because that would reduce the cost and burden in the intensive care. But we have seen patients with quite a severe, with severe forms that do gain some functions. So it's very hard to say how you would reduce the burden, but respiratory will respond, but less than motor. And again, it depends on how the kid starts.
Thank you very much. Any other question? Yeah.
Thank you very much, Dr. Valeria, for this interesting presentation. I would like to ask you about those with scoliosis that you present them at the end of your presentation. They got benefit of the treatment. I need your experience. They got benefit from having treatment?
Okay, so if you are referring to scoliosis, that is not, I think, so again, it depends on what we're talking about. If it's SMA1 kids.
No, I'm talking about SMA2.
SMA2 with scoliosis.
Yes, with scoliosis,
okay.
Because they have scoliosis, we can inject them, but I need to know your experience regarding the improvement, because here we should choose the patient cost-wise, if they will improve or not, because it will be we scheduled patient recently to get the injection. That's why we need to schedule them according to the priority. So I need to know if they will get benefit or not.
I understand. So the scoliosis won't improve with treatment, but you will improve the ability of the patients to maintain their sitting position, to have a better trunk control and head control, and better improvement of their upper limbs. So to me, this is sufficient for going with treatment.